Words Matter event, a conversation about stigma, substance use, and COVID-19. This event is hosted by RyCares and the City of Providence. Thank you both to the City of Providence and RyCares for supporting this conversation and working so hard on bringing us all together, especially today when we had these technical difficulties. So I also want to thank our sponsors, the Brown School of Public Health, Project Weber Renew, the COBRE on opioids and overdoses, BHDDH, and the Rhode Island Department of Health. Again, my name is Anna Bass-Moyer-Bell. I am a drama therapist and a playwright and the founder of Coast, where we utilize theater to address the overdose epidemic. I will be your MC or your facilitator today, and this event will run till about 12 o'clock. We'll probably most likely go over since we're starting about a half an hour late. And we have really an incredible lineup for you, so we're really excited. So I'm going to remind myself and the other presenters to slow down and take a breath. So I first want to acknowledge where we're sitting in history in this moment on Friday morning, September 25th, 2020. So we're currently all experiencing the global pandemic COVID-19, which has us feeling unsafe at times, uncertain about the future, and possibly disconnected from each other. We are also living through a major civil rights movement to affirm Black life and support the liberation, safety, and joy of Black folks in this country and beyond. These hard realities of systemic racism, white supremacy, and violence affect all of us and are incredibly painful to witness and work to change. We are currently also in the third decade of the overdose or opioid epidemic, from which recent reports say that overdose deaths have been on the rise since December of last year. And we all know that they are being exacerbated by the current pandemic. Again, feelings of uncertainty, pain, and fear. But there are also things to celebrate. September, this month, is Recovery Month. This month, we celebrate those in recovery, whatever that means to you, and those seeking recovery. In the United States, there are over 22 million people in recovery, which is over 10% of the population. Recovery is possible and it is glorious. Congrats to everyone here today in the Zoom room on your recovery. We celebrate you. So this is all a lot to bear witness to. And I don't know about you, but some days everything feels really, really heavy. And for a lot of you out in the audience, whether you are a journalist or work in the media and you're trying your best to report on the issues and on the stories, whether you're working in street outreach, noticing the difficulties in connecting folks to treatment, whether you're working in prevention and working in schools that may be remote or partially remote, or whether you're working in public offices and you're feeling pulled left and right, trying to address all of the aforementioned issues and more that are facing your constituents. We salute you. We know that you are doing the best that you can. And today we're going to talk about how we can help break down stigma within the words we write, the stories we tell, and as a whole, how we think about addiction and recovery. You will come away with a better understanding of stigma from different lenses, and you will have tools to support you in your allyship to dismantle the stigma that surrounds substance use. I want to say that, and I say this to a lot of clients when I'm working in therapy, it's not about being right or being perfect. You're going to make mistakes, and that's okay. But what it's really about is about understanding, adjusting, and trying to do better. In taking on this allyship and taking these actions that we're going to talk about, these are acts of love and compassion towards those that are struggling, their families, and our communities. Like I said earlier, I am a playwright. I've been writing and performing plays about the opioid epidemic for the last 5 years. And I have been able to see firsthand how the words that I write, the way I portray my characters, and how our interactions with audiences shape the way people perceive substance use and substance users. I found that writing dialogue that uses first-person language, creating short stories that show individual, complex, and the humanizing experience of addiction, help our audiences to better understand this experience, to better understand loss and the complications of loss to somebody um, to overdose, and recovery in all its glorious forms. So I will say that I've not always gotten it right. I've had to edit, rewrite, and sometimes apologize for stories that further entrench stigma. But in the end, I've been able to witness how storytelling and language can destigmatize and support those in our communities who are struggling and feel like their voice may be unimportant. Let's listen to those voices. So this morning, we will begin with Mayor Elorza, who will offer some welcoming remarks. Then we will have an incredible list of presenters, including the nationally recognized author and journalist Maya Salovitz, Project Weber Renews Ashley Perry speaking on the lived experience of stigma in Rhode Island today, RICARE's Machisti Rankin addressing the intersection of stigma against substance use disorders and anti-Black racism. Leading national researcher, Dr. John Kelly, will present the scientific evidence surrounding stigma and the language we use to talk about addiction and recovery. And RICARE's own Diego Arin Morley will talk about the particular forms of stigma faced by the Latinx community in Spanish language media. The presentations will last for a little over an hour, and then we'll have a panel discussion at the end where you all as audience members can ask your questions. So please hold your questions till then. If you have a pad of paper to write them down on, I suggest doing that. And we will invite you to ask questions in the chat box during that moderated panel. So before we get started, I just want to say this may feel really daunting to take on language and stigma and all of these issues surrounding it. And that's okay. We're all in it together. We're all here to support each other. But what we're really asking is for you as the media and for you that are working within this issue is that to lean on us, and that you don't have to invent the wheel. Like I said earlier, in 2017, the Associated Press style book offered guidance on destigmatizing language, which we will provide you with following this event. And our goal is for you to adopt these AP guidelines. And you're not alone. RICARES, working alongside state partners, will come to any Rhode Island or Massachusetts media organization and do a free 1-hour training on the importance of stigma, language, and the AP guidelines. So if this happened, if the media in Rhode Island all took on and adopted these AP guidelines, we would become a national leader. There's no other state in the country which all the media has adopted these guidelines. And we are a small state, but we are incredibly mighty. And I know that we can work to make this happen. So I also want to acknowledge that language change, like we talked about before with that question, really doesn't come easy or quickly, and things change. But you will be presented with lots of resources following this meeting to help support you in this journey. So we hope that this event and these incredible speakers will inspire you to think about the language you use and how it impacts people. You are all powerful storytellers. We hope that this will inspire you to continue to write stories that respect people's dignities, that has compassion for their pain, and highlights them as individuals and not categories or labels. And we hope that this all will bleed into a broader discussion about how we can talk about mental illness in a non-stigmatizing way. As I like to say, you are the hero in this story. So we're going to begin with opening remarks from Mayor Lorza, who I will introduce now. And I'm just going to ask again, Diego, will you come on and tell us about the translation, please?
Yes. Para una traducción al español en vivo, por favor, hace clic en el icono circular a la derecha del icono verde al fondo de la pantalla de Zoom. Cuando tú empujas ese icono que dice Interpretation, vas a ver una bandera que dice Spanish. Si tú eliges ese canal, todo será en español.
Thank you, Diego. So as Providence 38th Mayor, Mayor Jorge O. Elorza is driven by the belief that the strength of a community lies in the ability of its residents to share equally in its growth and progress. That is true democracy. Thank you. Since taking office in January 2015, Mayor Elorza has prioritized social, economic, educational, financial, and health equity, and opportunities for Providence neighbors and businesses. As a member of the United States Conferences of Mayors, Mayor Elorza serves as the Vice Chair of the Standing Committee on Community Development and Housing. He co-chairs the Committee for Immigration Reform and is the member of the conference's advisory board. The mayor has been an outspoken national voice on issues such as immigration reform, healthcare, and environmental protection, placing an emphasis on the work done at the local level. Born and raised in Providence, Mayor Elorza is a graduate of Classical High School, the University of Rhode Island, and Harvard Law School. Prior to being elected mayor, he served as the Providence Housing Court judge and co-founded the Latino Policy Institute, while he served as a professor at Roger Williams Law School. Mayor Elorza lives with his wife Stephanie and his son Omar in the Silver Lake neighborhood.
All right. Well, buenos días a todos. Good morning, everyone. Thank you, Annabeth, for moderating this conversation and for getting us started in the right way, for setting the tone. I want to echo Annabeth's comment that you are all the heroes of this story. I think that's a perfect way to put it. To borrow again from Annabeth's introduction, this is a very daunting task that we're all undertaking. But how do you eat an elephant? One spoonful at a time. And bringing everyone together in this way, this isn't just a spoonful, this is a bowlful. And so I look forward to all the work that's going to come from this. Last, I want to thank everybody for your patience. I know that we had some technical issues, but it seems like we're all on board now and ready to rev and roar. So good morning once again. It's really exciting to see so many people join us, particularly since it's folks from so many different disciplines that have come together for this event. I'm so happy that we've gathered, and as we speak, the country, our state, and our city continue to face an ongoing opioid use crisis. Rates of opioid overdose are on the rise and have only increased and have been exacerbated during COVID-19. Community health and well-being are incredibly vulnerable right now, and we know that now more than ever, we need to respond to these diseases of despair to our neighbors who are struggling, and we need to make behavioral health issues a priority and truly make them a priority. COVID-19 has added so many economic and health stressors, as well as exposed racial inequalities across our country. The virus has presented a unique set of crisis circumstances that make it physically and symbolically more difficult to reach out and to connect with our neighbors. Nonetheless, we've seen incredible acts of kindness. We've seen people come together to fight for social justice, and we've made a recommitment to making our communities more inclusive. As many of you have, I've had a front row seat to observe substance use disorders and know how far we've come in terms of breaking down barriers to care, destigmatizing treatment itself, and shifting our language to talk about people as people instead of as defined by their substance use. The words that I use matter. The words that we teach our kids matter. The words our doctors use matter. The words that our journalists use matter. And it costs us nothing to say the right thing. That's what makes today's meeting so exciting. We have a unique opportunity to learn from field experts and also from our neighbors who have been through treatment and recovery. In the spirit of adapting the language Providence uses to reinforce equity and inclusion, we are updating our own word choices as well. While we're all gathered, I'm proud to announce that the city's Substance Abuse Prevention Council is undergoing a name change. Via executive order, the council has been renamed the Mayor's Coalition on Behavioral Health. Thank you to Healthy Communities Office Director Ellen Sinar for championing this work. You know, this body of work dates back to 1987 to address substance use issues, and now its name will reflect the holistic, destigmatizing work that the coalition has and will carry out. Thank you to all the brave neighbors and colleagues who will share their stories today. And thank you to everyone in attendance who's willing to participate in this difficult conversation that will not follow, that will challenge how we think and how we speak. Changing the conversation and the terms of debate will make a difference, and you all are a big part of that today. So thank you, and I look forward to a robust conversation and progress being made on all of these issues by us coming together collectively. I'll hand it back to you, Annabeth.
Thank you, Mayor Lorza. What an incredible step in your allyship. We really appreciate that. I'm like trying not to be emotional. I want to acknowledge that words really do matter. Thank you for saying that. Words matter a lot. And in the words that we use, we can reaffirm people's life and we can reaffirm our love and compassion for them. So thank you. So we are going to move on to our first presenter, Maya Salovitz, who is the author of the New York Times bestseller, Unbroken Brain, A Revolutionary New Way of Understanding Addiction, which is widely recognized as an important advance in thinking about the nature of addiction and how to cope with it, personally and politically. Her book, Help at Any Cost, How the Troubled Teen Industry Cons Parents and Hurts Kids, was the first to expose the damage caused by the tough love business that dominates adolescent addiction treatment. She has written for numerous publications, from High Times to the New York Times, including Time, the Washington Post, The Guardian, Vice, Scientific American, and The Atlantic. She has won awards from the National Institute on Drug Abuse, the Drug Policy Alliance, the American Psychological Association, and the American College of Neuropsychopharmacology, which is a very long word, for 30 years of groundbreaking writing on addiction, drug policy, and neuroscience. So welcome, Maya.
Thank you so much for having me. I am really delighted to be here. And yeah, this pandemic has been absolutely terrible. But I think there is at least one silver lining. That is that suddenly the term harm reduction has popped up everywhere. We see it in the Times, in the Washington Post, all over the place. And what a lot of people don't know about that term, like oftentimes people say, oh, it came from AIDS, it came from, ACT UP or something like this. Well, actually, it was developed by and for people who use drugs. So what is harm reduction? So in drug policy, it's the idea that we should focus on reducing harm, not on stopping people from getting high. Personally, I think that if you want to have euphoria, I don't really care. What I do care about is if you hurt yourself or someone else. And harm reduction wants to apply that to policy. Now, more broadly, harm reduction is also about how people change behavior. And the reality is that most people do not change overnight. Slowly, with setbacks and spirals and circles and all kinds of different experiences, people do get better. But if we see it as a sort of black and white issue, abstinent or not abstinent, we often don't recognize the real progress that people make. So for example, if you start using a clean needle, you are doing something very good for your health and for the health of your community. And you are protecting yourself, you're protecting other people. And suddenly you start to think, well, hey, I just did take a positive step forward. Maybe now I can get some of that naloxone, and in case somebody overdoses, I will reverse it. Okay, great. Now I've saved my friend's life. That's amazing. And I can see that I'm a valuable person in a way that maybe I wasn't able to see before. And maybe I want to cut down. Maybe I actually want to stop. Right? So this is how harm reduction works in process, and how people with compassionate and supportive care that isn't judgmental get better. So how does this apply to COVID? Well, if you see preventing COVID as being perfect, and you have to clean every surface, you got to bleach your packages, you've got to like wash your hands every 10 minutes, you got to wear a mask even in the house. Well, no one's going to be able to keep that up for very long, right? And when you do break, you're probably going to just do something really super risky. This is what happens when people go from abstinence to non-abstinence, basically. So if we apply a harm reduction approach to COVID, then we can reduce the risks where the risks are riskiest, and we can manage the risks that we think are acceptable to take. We can just wear the mask outside, for example. And so this is really important, because when this pattern is seen when people have binge-like behavior. And if you see a binge as like ruining everything that you've done previously, it's going to be much harder to get out of the binge and to get better. Because, well, like I just screwed up the whole thing. I may as well have 10 drinks, even though I just had one. And this can really become a disaster. In fact, it's known as the abstinence violation effect. Anyway, so if you do harm reduction, you focus on reducing the biggest risks. And it allows you to think about risk in context. And it was devised by a group of drug users and researchers in Liverpool and Rotterdam and Amsterdam in Europe. Okay. So let's talk specifically about stigma. This was devised, it's identified and defined as spoiled identity by the sociologist Erving Goffman. And that, if you think about that for a minute, that's exactly what people who use drugs experience. We are rejected, we are attacked, we are seen as the lowest of the low. I am a person in recovery, I should note. And so, it's just a horrible experience. We don't need the word to tell us that we are outcasts, and it's bad. So we want to try to change that. Now, I want to say here that this is a totally uphill battle, because criminalization of drug use is intended to produce stigma. Criminalization cannot work if it doesn't produce stigma, because if you think it's perfectly acceptable, then you are not going to worry about going to jail or whatever. The criminalization and the criminal tag for people with addiction means that it's very hard for anybody to take it seriously, the idea that it's actually medical, because we're speaking out of both sides of our mouth. We're saying these are horrible, bad people, but they deserve compassion. And so that creates a real obstacle. And if we really want to move forward in terms of policy and in terms of really reducing stigma, we need to reduce criminalization. Let me speak a little bit more about why people stigmatize. In our drug war, which was founded for racist reasons, a lot of people think, the FDA sat down one day and said, these drugs are safer, so they'll be legal, and those drugs are unsafe, so they'll be illegal. This is not what happened. What happened was a series of racist panics and anti-immigrant panics that also helped drive alcohol prohibition. So all of this means that our racist stereotypes line up exactly on our stereotypes about people who use drugs. And this is very hard to disentangle until we recognize the role of racism in the drug war and in the way we see substance use issues. If we are going to see it as medical, again, we've got to stop this and be anti-racist. One other piece about stigma, we definitely stigmatize things that we fear, and addiction represents fear of being out of control. So we have to identify that within ourselves And if we are feeling revulsion around addiction, we have to recognize that where that comes from and address that, not take it out on other people, right? Okay, so now I'm going to talk specifically about language here. Whoops. Sorry about this. So we need to, obviously terms like junkie, addict, druggie are stigmatizing. Instead, we need to use language like person with addiction, person with substance use disorder. The media is not going to use. When you get paid by the word, it's nice, but your editor is going to take it out. So person with addiction is perfectly acceptable. Now, if people want to identify themselves and say, I'm an addict or whatever, I personally think that whatever a person does for their recovery is okay, if that's what they think is okay for them. Now, we can challenge them, we can talk to them about it or whatever, but just like other groups have reclaimed stigmatizing language, I don't want to deny this possibility to people with addiction if they want to do that. So if people want to call themselves whatever, let them do what feels right for them, I believe. Now, abuse. This is a terrible thing. We are not abusing a poor little drug, right? What it does is it associates people who use drugs with child abusers, domestic abusers, sexual abuse, all kinds of terrible things. This is a ridiculous term. So misuse is perfectly fine. Now, I like to distinguish between use and misuse because the vast majority of people who use drugs, including alcohol, caffeine, not including tobacco, but including the illegal drugs, the vast majority of those people are not addicted and are not harmed. So we have to distinguish between use and misuse and addiction. So DSM dropped the term abuse in 2013. We should be beyond this at this point. Okay. So let me just mention the baby issue here. A baby cannot be addicted. Addiction is compulsive drug use that continues despite negative consequences, and dependence is physically needing something to function. So a baby might have physical dependence and suffer withdrawal as a result, but that baby cannot crawl out of the hospital, go buy drugs, compulsively use them despite negative consequences, because it's really hard to do that if you can't speak, right? And if you can't, if you don't have any money and you're in a onesie, right? It's like not gonna happen. So we need to take that stigmatizing term away from babies. And we also need to truly distinguish between addiction and dependence. This is a critical thing. I'm so glad that the AP included this, because unless we do this, we cannot destigmatize medication for addiction. We can't destigmatize babies who are affected by drugs, and we cannot destigmatize pain treatment with opioids, which sometimes produces dependence. Okay, so what is dependence? Dependence, physically needing something to function. I could be dependent on Prozac. You could be dependent on blood pressure medication. Some people might actually die without certain blood pressure medications from the withdrawal, but nobody goes around compulsively seeking them or robbing drugstores for them, right? So these are two different things. And when you take medication for addiction treatment, which I should add and did not previously, we don't say we have Prozac-assisted treatment for depression. We don't say we have, blood pressure medication-assisted treatment for high blood pressure. We treat the disease with a medication. And in fact, for addiction, we have two medications that are proven to cut the death rate by 50% or more. These are methadone and buprenorphine when used long-term. But when you use those medications long-term, you are physically dependent on them. But your life has gone from compulsively seeking a drug that's doing harm to being able to function, love, work, do whatever as well as anyone else can. So that is dependence, that is not addiction. And similarly for pain patients, some pain patients do benefit from chronic use of opioids. They, again, are physically dependent and not addicted. I just want to end by saying that most people who work in journalism aren't educated about these language issues. People just don't think about them. They just do what has been done previously. In order to change, we have to make people aware and we have to bring them in. Once you recognize that, we don't say schizophrenic anymore, we say person with schizophrenia. If we're going to do it differently for people with addiction, that in itself shows that we see addiction as a crime rather than a disease or a medical problem. So journalists do want to do the right thing. I think if we bring them in, it can be really helpful. I should have had a slide on this, but I do not. But I want to mention a website that I created along with a couple of other people called changingthenarrative.news. And this has a lot of information on how to better use language as a journalist. And thank you all so much.
Thank you so much, Maya. I'm cueing applause, you just can't hear it. I'm sure people are applauding at home. Thank you. I think one of the things that really stands out for me from what you're talking about is how we can break generational stigma. When you talk about babies, we're passing stigma from mother down to baby, and so if we don't use the word addicted baby or crack baby or all of those things, right, we're breaking that generational stigma, and we're breaking generational trauma too, and pain and hurt and judgment. So that's really, really powerful. Thank you for all of your work in writing. I have your book on my bookshelf, and it's just really a pleasure to meet you. So moving on, we have an incredible woman coming up to speak. Her name is Ashley Perry. She currently serves as the intervention case manager at Project Weber Renew. Project Weber Renew is a peer-based harm reduction organization that provides a spectrum of services, from harm reduction to recovery supports, including syringe exchange, overdose prevention, HIV prevention care, and basic needs. Project Weber Renew serves some of Rhode Island's most vulnerable residents with a focus on people who use drugs, people who engage in sex work, and those who are HIV positive or at risk for HIV. Ashley is a trained, qualified professional test counselor for HIV and Hep C, a Narcan Train the Trainer, and she is currently the co-chair for this year's World AIDS Day celebration, working on the Rhode Island HIV and STI Prevention Coalition. Ashley is a harm reduction leader in the state, simultaneously providing street-based outreach for stigmatized populations and advocating on the state level for systemic change. Welcome, Ashley.
Thank you, Anna. Hello, everyone. If I told you today that my friend died very unexpectedly from heart disease, she was only 24 years old and left behind 2 babies, you, society, would probably say something to me along the lines of, that is so tragic, or what could I do to help? And the same would probably be very true if I replaced the word heart disease with cancer or even kidney disease. But if I told you the same exact story and replaced any of those diseases with the word overdose, you, society, would probably say something to me like, they should have known better, or those children would have been better off. That is one of the most basic examples of stigma that I hear all the time. I can remember my early days of working with Project Weber Renew. I was what they call very bright-eyed and bushy-tailed. I had this assumption of what the work I would be doing looked like. I thought I was going to prevent the spread of HIV. I thought I would be helping vulnerable women escape the life of human trafficking. And most importantly, showing people that I serve that recovery is possible. Although those are all very important things that I still work on today, they by far don't compare to the silent war that has been waged on the folks that I serve, and that is the war on stigma. In preparation for today, I put so much thought into what I really wanted to say. I realized that this platform I was given may be one of the most important of my career. This could be our real shot at breaking down the walls stigma builds up. So I Googled what stigma really meant. And the definition says, a mark of disgrace associated with a particular circumstance. And when I dug a little deeper, reading into the history of the word stigma, I learned that in the 1950s in England, Stigma was an actual mark that was tattooed or labeled with a cast iron to let everyone know that the person was a criminal. And I thought about how parallel that is to how we treat addiction today, when for most, the only treatment for addiction is incarceration. People wonder why I call the challenges we face with stigma a war, and it is because it is just that. We are losing someone in our country every 11 minutes to an overdose. I personally would consider those mass casualties. And the facts are that 1 in every 10 person experiencing addiction does not seek help. And every day I see the barriers that are stopping them. I see it in my client who had an infection in his leg a few weeks ago. And when I asked him if he wanted to go to the ER, he politely replied, "No, I know they'll just bandage me up and kick me out thinking I'm only looking for a bed for the night." That same man is in the ICU today fighting for his life with a staph infection taking over his whole leg and pneumonia in both his lungs. I see stigma when I bring a client to a detox center and they say things like, "Hey, Sally, you're back again. Maybe this time you'll get it right." Or my personal favorite, "You're back for another vacation." Imagine again me saying this to someone who just had a cancer relapse. How horrible of a person would I have to be to say, "Well, I hope you get it right this time. Maybe the chemo will work." But sadly, this is the true reality of how we treat people who use drugs. We minimize the importance of their treatment, and we look at their illness like a moral choice instead of the disease that it really is. I think about how we learn stigma and how it comes from everywhere. I see it in the movies that glorify drug use. I see it in headlines like "Drug Addict Held for Stealing Jewelry from Kin's House." I thought about what I learned about drug use as a child. My own mother battles addiction, and because of her addiction, she did not raise me. I was taught as a child that my mom was a bad person because of her drug use. I was taught that she loved drugs more than me. And when she tried to get treatment through things like medical assisted treatment, I was taught that she was only now legally getting high. Those became my own perceptions of people who use drugs, because again, it's what I was taught. I was never taught the truth about addiction, that it is a disease, or for that matter, about generational cycles of addiction. As I got older, I started seeing how wrong everything I was taught was. You see, all the stigma that I once held against my own mother was still soon smacking me in the face, because I too have the disease addiction. I remember thinking one day how ironic it was that I turned into something that I despised the most. Unfortunately, because of the stigma I was already taught, it took me so long to realize that I did not choose to become a drug addict. I wish more than anything that I could be like my friends who drink on the weekends, who do drugs recreationally without it completely taking over their minds and lives. But for me, it does. Even more so, that stigma held me back from getting real help. I was scared. I was scared of being labeled. I was scared of becoming part of the system. I was scared of losing my children. That fear of being stigmatized kept me hidden, and I'm sure it does for so many more. Today, mostly through my work, I've grown very thick-skinned to stigma. When approached with stigma, I try my hardest to use it as teachable moments, to educate someone. But every so often, I'm still hurt by stigma. I can remember the day that I met our governor. I was excited because I wanted to speak to her about the future of overdose prevention centers in our state, and how I felt honored to sit on the governor's overdose task force, and how I'm truly grateful that she is helping to bring our voices to the table. So my boss introduced us. She told the governor that I'm a peer in long-term recovery working on the opioid crisis. The governor replied, "It's nice to meet you. How long have you been in recovery?" And I told her a little over 6 years, very proudly. And she said, "Wow, you look great." I was honestly taken back by that. I wanted to say, compared to what? You see, it's those types of very unconscious bias that's built up from stigma that keeps us boxed in. Because now I did not speak to the governor about anything that I originally planned to. Instead, I thanked her for what I guess she thought was a compliment. If I could do that moment all over again, I would teach the governor. I would tell her that the same unconscious bias of what someone on or off drugs is supposed to look like was something that fueled my own addiction. When I used drugs, unless you were doing drugs with me, you would have never have known. Because of my fear of stigma, I made sure to appear perfect to the outside world. And again, those fears held me back from getting the help I really needed. Today, I'm asking all of you to join us in this fight. Educate yourself, educate your children, educate anyone who will listen to you. Addiction is not a moral failing. It is not a weakness. In fact, some of the strongest people I know, like my own mother, have the disease addiction. I encourage you to come out to where I work, Project Weber Renew, and meet some of the beautiful people that I serve. And I encourage you to take part in RICARE Stigma training and really challenge yourself. Help us break down the barriers that stigma has built up and spread the message that it is okay to be sick. I am asking you to help us save more lives. Thank you.
Thank you, Ashley. I want to just give us a moment to take a deep breath in. And with that deep breath in, we are sending Ashley and her children and her mother all of our love. So in through your nose, out through your mouth. Thank you, Ashley. I'm going to try to keep going without crying. We appreciate your story. And I think this call to action, right? There are little Ashleys all over the world listening to us, right? Listening to our stories, listening to the things that we say, reading the things that we write. And how can we help support those little Ashleys all over the world to believe in themselves, to love themselves, and to love their families. So thank you so much, Ashley, for your story. And I just see all these wonderful comments coming into the chat box. Thank you, everybody. Okay, all right. We are gonna move along to Dr. John F. Kelly, who just, oh no, sorry, Machisti. I didn't forget you, Machisti. We're going back. We're not going to Dr. John Kelly yet. So we are going to Machisti Rankin, who a lot of us know and love. He is the Community Outreach Coordinator at RICARES, the co-chair of the Advocacy Committee, and a peer recovery specialist. After over a decade of working in law enforcement, he is now the co-chair of the Providence Civilian Oversight Board, where he works towards greater police accountability, which is incredibly needed right now. Thank you, Machisti. He was born in Syracuse, New York, and he grew up in Rhode Island, which doesn't actually make you a real Rhode Islander. But he is also the father of 2 children, and he enjoys reading. So thank you, Machisti.
Thank you very much, Annabeth, and thank you all in attendance today. Good morning. My name is Machisti Rankin. Today, I want to speak about recognizing how the exaggerated fears of addiction and drug use have been weaponized against Black people as part of the war on drugs. Yeah, I know. Here we go again with another Black person talking about race, talking about the war on drugs. But this war has had consequences. This war has led to mass incarceration, lethal over-policing, and a deepened stigma against people who use drugs. This is all strongly tied to racism. From the fear that Chinese immigrants were somehow causing whites to use opium, to the idea that white women were being seduced by Black jazz musicians with marijuana, to the current occupant of the White House stating that Mexicans bring drugs and crime. Stigmatizing language, coupled with substance use, is an effective tool that is often employed against Black people and other minority groups. It furthers the mentality that we are those people, the others. This helps to feed into the stereotype that Blacks use drugs more than whites. That's simply not true. Blacks and whites use illegal drugs at the same rate. Some might say, but Machisti, Blacks smoke more crack than whites. No, my friends, that is also not true. But Machisti, surely you can't argue that Blacks aren't bigger drug dealers than whites. Actually, my friends, whites sell illegal drugs at slightly higher rates than Blacks do. Now, if you said that Blacks are arrested and convicted of drug-related offenses at a substantially higher rate than whites are, that would be a correct statement. As I speak to you today, Americans are marching in the streets to protest the murder of yet another Black person at the hands of police. We all know how this is going to play out. Coverage will begin with a focus on the peaceful protests, which the majority of the protests are. But as soon as a window is broken at a target, we'll switch our focus from the real reason behind the protest and focus on the rioters and the looters. That will then become the major story. Some might say that these things are separate issues. They're not. When journalists use stigmatizing language to tacitly justify a person being murdered, they're not helping. Did George Floyd have fentanyl in his system? Let me be clear. I don't care. Being high is not a capital offense. Was Breonna Taylor's ex-boyfriend engaged in the trade of illegal narcotics? He was. She was not. Breonna Taylor. Breonna Taylor. Breonna Taylor. There's nothing wrong with your Zoom. I'm saying her name. You say it too. But they were Black and illegal narcotics were somehow connected to them, so they deserved to die. We know that Blacks and other minorities are dying at a disproportionate rate from COVID than whites are. To that, some might say they had underlying conditions. Why did they have these underlying conditions? It's not because of a lack of values or a lack of work ethic. It's because of poverty and a lack of access to healthcare. Socioeconomically disadvantaged people live shorter lifespans and have higher rates of depression. According to Statista, 18.8% of Blacks and 15.7% of Hispanics live in poverty. That is compared to 7.3% of whites. Some people might decide to ask a Black colleague in their office what they think about this subject, but you'll find that pickings are slim. According to the Pew Research Center in 2018, 3/4 of newsroom employees are non-Hispanic white. So unlike Meghan Trainor, who was all about that base, newsrooms are all about that race. Well, you can change that. We tell children that words hurt. We expect for them to be mindful of what they say and how they say it. The ask today is that the media be mindful of what you collectively say and how you say it. This is not an attempt to play word police. Instead, it is an opportunity for the media to participate in harm reduction, to lessen the stigma associated with substance use disorders, to be mindful that words matter. Again, my name is Machisti Rankin. I am a proud Black man, a dedicated father, and a person in long-term recovery from alcohol use disorder. Thank you.
Thank you, Machisti. I want to say you are not just another Black man. You are an incredible Black man, and we hear you. So I want to also echo the name Breonna Taylor, and I would like to take 10 seconds for us all to have a moment of silence and be thinking about Breonna Taylor and all others' lives that have been lost to police violence. So 10 seconds of silence. Thank you. Thank you, Machisti. Your voice is incredibly important. All right. It's really hard for me to move on, but we're going to keep moving forward. Now we are going to move to Dr. John Kelly, who is the Elizabeth R. Spallin Professor of Psychiatry in the field of addiction medicine at Harvard Medical School, the first endowed professor in addiction medicine at Harvard. He is the founder and director of the Recovery Research Institute at Mass General Hospital, the program director at the Addiction Recovery Management Services, and the associate director of the Center for Addiction Medicine at MGH. Dr. Kelly is a past president of the American Psychological Association, Society of Addiction Psychology, is a fellow of the APA, and a diplomat of the American Board of Professional Psychology. I wish you could see all of the all of these written out. It's pretty amazing. He has served as a consultant to the U.S. federal agencies such as the White House Office of National Drug Control Policy, the Substance Abuse and Mental Health Services Administration, SAMHSA, the National Institute of Health, NIH, to national non-federal treatment institutions such as the Hazelden Betty Ford Foundation and Karen Foundation, and to foreign governments. Dr. Kelly has served as a consultant to the United Nations, representing the US summits discussing substance use treatment, stigma, and discrimination. He has published more than 140 peer-reviewed articles, reviews, and chapters in the field of addiction science, and is currently an associate editor for several academic journals in the addiction field. Dr. Kelly was an author on the US Surgeon General's report on alcohol, drugs, and health, and he works with Psychology Today as a monthly contributor. And I assume that Dr. Kelly also does not sleep, because that is an incredible list of achievements. So please help me in welcoming Dr. John Kelly.
Thanks, Annabeth. Hope you can hear me okay.
Yes, we
Terrific.
can.
Thank you. I am delighted and honored to be here with you all among such distinguished panelists. Thanks for having me. I'm going to share my screen with you so you can see my slides. Can you see that?
Yes.
Great, thank you. So I'm going to talk a little bit from the kind of policy and scientific perspective on what we know about stigma, particularly around language. You know, I've been reflecting a lot this year, last year too, just because it's coming up for 50 years, a 50-year milestone since the declaration of the war on drugs, really under the Nixon administration. And when you think about the language associated with the rhetoric of the law on drugs, that is actually changing, I would argue, thanks to people like those who are on this panel today and you all here. One of them, I think, you know, when you think about the rhetoric that was used back then as drug abuse, quote unquote, being public enemy #1, I think today we would refer more to the drug problem or drug use disorders as the top public health problem. There's been a shift in our overall approach. It's taken 50 years. Our laws reflect that. If you think about the harsh punitive laws in the 70s and 80s, like the Anti-Drug Abuse Act with mandatory minimum sentences, which disproportionately affected ethnic racial minorities, towards more recent laws like the Mental Health Parity and Addiction Equity Act, the Affordable Care Act, most notably, which made substance use disorder an essential benefit. And that's good news. I was actually at the first ever Drug Policy Reform Summit held at the White House on December 9th, 2013. Why was I invited? I was invited because they wanted to address stigma, and I'd actually been doing some research on stigma and language and how important language is in conceptualizing these disorders and how we approach them, because our language not just reflects, but affects how we approach these problems. Here's another thing. Annabeth mentioned that I was a consultant to the United Nations. I went there in January to Vienna to talk about stigma and how it can address stigma related to drug problems worldwide among nation states members of the UN. Now look at this outside. Can you see this down the bottom right? This is the only monument outside of the United Nations. This is the Office of the United Nations Office of Drugs and Crime. This monument is dedicated to all those affected by drug problems worldwide. Drug problems are preventable and treatable. Now that warmed my heart. I thought, wow, look at that. There's a monument. That's not going anywhere, that monument. That's steel and concrete. That's meant to stay. And it's a testament to the way we are changing. I think we got a long way to go, but it's good news that the UN Office of Drugs and Crime is moving towards destigmatization as a way to help prevent discrimination against people who use drugs and with drug problems and people in recovery. Another thing that's happened, this is the International Society of Addiction Journal editors. I went to Budapest in 2015, presented some of the data I'm going to show you today, and they adopted a consensus statement across all addiction science journals worldwide to remove the term abuse from published addiction science. And so that's another important step that the scientific community has adopted by consensus, that we need to shift this language because it's punitive, it's stigmatizing, it doesn't help. So what is stigma? There's been several definitions already proposed this morning. Here's another one, which I like. Stigma is an attribute, behavior, or condition that is socially...
Were they closing the dryer? You put closing the dryer?
What is discrimination? Discrimination is the unfair treatment of individuals who have that stigmatized condition. So there's two distinct aspects there. The stigma is what is the condition, attribute, or behavior, and discrimination is the unfair or unjust treatment of those who have the stigmatizing condition. Now, obviously, we're here because there's a lot of consequences to this. Sometimes it's leveraged in a, perceived to be a positive way, but it can be very harmful. It can also affect how money is appropriated and to what kinds of resources. Should we pump money into the criminal justice system to address these problems, or should we pump money into public health approaches, for example? What's the best approach? And stigma affects where that money goes. It also affects employment, barriers to employment, housing, and other kinds of factors that can help people overcome drug problems. On the personal front, it can lead to, stigma can lead to, and discrimination can lead to lowered self-esteem, shame, guilt, delays in help seeking, early dropout from treatment, and less treatment engagement. These are the common dimensions that are studied when we look at stigma. Blame. Are people responsible for having their condition, problem, attribute? Can they control it? Are they engaging in selfish self-indulgence? Prognostic pessimism is another dimension which is often studied. Can people get well who have a drug problem? Can they recover? Are they dangerous? Can people be trusted who have had a drug problem or have a drug problem? And social distance, that's related to dangerousness. Would I have them be a babysitter? Would I have someone, would I have someone as a roommate? Turns out that when we look at all stigmatized conditions across different societies, illicit drug use rises to the top. This was a study across 14 countries, 18 of the most stigmatized conditions, including being a criminal, being HIV positive, and being an illicit drug user and illicit drug user, alcohol. And across these 18 conditions, 14 different countries, universally across these countries, number one was illicit drug addiction. Number four was alcohol addiction. So two of the top four were to do with substance use. What do we know from the science about stigma and discrimination related to people who have these conditions? We know, as I mentioned, substance use disorder is very stigmatized. It's in fact more stigmatized than any other psychiatric illness, which are first cousins of substance use disorder. They're all psychiatric illnesses, but substance use disorder tends to be more stigmatized. People are perceived, in part, I think, is because people are perceived as more to blame for having the condition because it involves initial choice that provides the exposure. And I'll talk about that in a minute. Describing substance use disorder as treatable helps. It helps reduce stigma when people know, we can treat it and people can recover from it. And patients themselves who hold more stigmatizing beliefs, irrespective of how severe they are less likely to seek treatment and discontinue sooner. Here's the other thing I think very important from a clinical and public health perspective is that physicians and clinicians are shown also, just like other members of society, to hold stigmatizing biases. We might not think so, but this has been shown to be true again and again. But the good news is that there's something that we can do about that, and that is education. So education seems to help when we educate clinicians and physicians about the nature of substance use disorders, what they are, how they're caused, et cetera, can help reduce stigma. So why is addiction so stigmatized compared to other social problems and conditions and other psychiatric illnesses? So if you ponder that for a second, why is it? Why do we have this problem in the substance use field and we don't have it in other kinds of areas, including other kinds of psychiatric illnesses? Well, I think it has to do with this notion of choice, right? Is that initial exposure? Yeah, people have to say, yes, I'll have a drink. Yes, I'll smoke that cigarette. Yes, I'll take that line of cocaine. Yes, I will try some opioids. But there's something else that happens thereafter, which I'll talk about. And it relates to these two dimensions of cause and controllability, which are two factors which strongly influence the degree of stigma attributable to different problems, behaviors, and conditions. If we can say, for example, it's not their fault and they can't help it, stigma tends to decrease. On the other hand, if we say it is their fault, they did cause it, and really, you know what, they can help it, they're just engaging in selfish misconduct, stigma tends to go up. And this just depicts those two dimensions and how they are correlated. Now, what have we learned in 50 years of genetics and neuroscience? You know, one of the things that happened under Nixon was the birth of the NIH, NIAAA, NIDA, later on SAMHSA, CSAT. All these federal agencies came along to help understand the etiology, epidemiology, the clinical cause, how we can treat these conditions, how they're caused. We've learned a lot about addiction and substance use disorders, that they are genetically influenced, strongly genetically influenced. In fact, about half the risk for an addiction problem is conferred by our genetics. Some of us are protected, some of us are more vulnerable, like other complex illnesses. Also, we've learned a lot from the neuroscience in the last 30 years in particular through neuroimaging. We understand much more about neuroplasticity, how the brain is changed as a function to chronic exposure to very potent seductive drugs. That changes the brain neurocircuitry and neurochemistry of reward, memory, motivation, impulse control, and judgment. These can be radically affected, not just functionally, but structurally. You don't have to look very long or very hard at this bottom right image, comparative image between someone who's addicted to alcohol on the right and somebody who's a moderate drinker. There are observable, clear structural changes which have occurred as a result of chronic exposure to a neurotoxic drug like alcohol. So what can we do about discrimination and stigma, given that these disorders seem to be so stigmatized? Now, I think, you know, education, as I mentioned, and I've just showed you what we've learned about genetics. These are complex illnesses. They're genetically influenced, like many other illnesses from which people can suffer. And the brain, it can be radically affected and radically impaired. This is why it's a psychiatric illness. If this wasn't true, it would not be in the DSM, in the DSM. It's a psychiatric illness. It means there's something gone awry in the brains of these individuals which produce the impairment despite severe and harmful consequences. So how can we start to get that across to people so that they understand a little bit more about the nature? And if we were to do that, would we start to reduce stigma? So education is one path that we can do that. Personal witness is another, and this is a big movement nationally and internationally now, started here in the United States, to put a face and a voice on recovery. There are many people I know in the field who openly talk about being a person in long-term recovery, to help deconstruct these stereotypes, the biases that people have, the prejudices people have about people and what a quote-unquote addict looks like. And the other way, another third path, is through changing our language and terminology. So it would be nice if this was all very straightforward and very clear. It's not, it's slightly nuanced. So here's a question. If we were to emphasize these biomedical aspects, just plainly emphasize them, that these are biogenetic influenced diseases and disorders, and they have neurobiological impacts which affect self-regulation and inhibitory control, would that reduce stigma? Well, interestingly, yes and no. This is a meta-analysis, quantitative review of 28 studies that looked at, and this is in the mental health field actually, not in addiction specifically, but what they found was that when they emphasized the genetic influence of mental illness, they found that yes, it did actually reduce blame. Okay, so that's one element of stigma, as I mentioned, those different dimensions of stigma. It did reduce blame, but here's the kicker. It increased stigma of social distance, perceived dangerousness, and prognostic pessimism. People think you can't get well if you have a genetic disease or genetically caused disease. What about controllability? That was to do with cause. What about controllability? And here they looked at the neurobiological impact of chronic exposure, but here they were looking at mental illness again. And what did they find? Interestingly, when the neurobiological aspects of mental illness, kind of the chemical imbalance idea, when that was emphasized, what they found was that actually had no effect on blame, and it still increased social distance, dangerousness, and prognostic optimism. So not exactly what we would think or want. So what about in drug impairment specifically? This is a study, we've just finished this study, it's just under review now, it'll be published soon. But one of the things I wanted to look at was in addiction, how we describe these disorders, what impact does that have on perceptions of dangerousness and prognostic optimism, et cetera, the same dimensions. So I compared these different ways of describing addiction as a chronically relapsing brain disease, as a brain disease, as a disease, as an illness, as a disorder, or as a problem. And these were randomized, those terms were randomized to the general public, 3,600 members of a nationally representative sample of the US general population. Interestingly, what we found was that similar to those other studies in the mental health field, that when the more biomedical term was used, it did tend to reduce blame, perceptions of blame. So if you look at the top graph here, people who are exposed to the vignette describing a drug-impaired person as having a chronically relapsing brain disease, they were viewed as less to blame than every other term that was used. Conversely, if you look at the bottom graph, that actually had the worst outcome in terms of viewing the person as being able to get better, which actually describing someone as having an opioid problem, that was associated with less perceived danger, social distancing, and better prognostic optimism. So what does that suggest? It suggests that maybe there's not one universal way of describing these phenomena that is applicable in all circumstances, but rather we might need to choose what particular way we want to describe these disorders and how to describe them, people with them, depending on the communication goal. To reduce stigmatizing blame, for example, we might want to use more biomedical terminology, but to promote prognostic optimism, we might want to drop that in favor of less biomedical terminology. Here's the other thing, is that we know that most people who have a substance use disorder will eventually get into recovery. There was just a paper published based on the National Survey of Drug Use and Health, where they just asked for the first time last year about recovery status. 75% of people who had a substance use disorder were able to achieve remission. That's full sustained remission, that's 12 months or more without symptoms. That's the good news. Now, I'm not discounting the terrible losses that we have every year related to opioids and other drugs, including alcohol, of course. But it's a good prognosis disorder. It can take people a lot of years to get into recovery, and it can be a traumatic and a very bumpy road, but most people do recover. That's the good news. These disorders are preventable, they are treatable, and most people recover. I think coupling that with these other notions about the biomedical, the genetic, and the neurobiological, but promoting that, but also communicating that these disorders are treatable and that most people recover. That gives people hope, gives families hope. If you hang in there, you keep trying, that you can get into recovery. The last thing I'm going to talk about is terminology. And this is, other people have brought this up already this morning, and we have a vast array, maybe a colorful array, I've used color here, but no pun intended there actually, but it's certainly a colorful array of language that we have in our field, right? That to use to describe the nature and course of these problems, as well as people who have them. And Maya Salovitz already mentioned some of these more, negative terms that we hear and we read about. Here's a question that I asked myself a while ago that I'll pitch to you all to consider. People with eating-related conditions are always referred to as having an eating disorder, never as food abusers. So why are people with substance-related conditions referred to as substance abusers, or drug abusers, or alcohol abusers, and not as having a substance use disorder? You never hear anybody talk about, I work in the food abuse field. Yeah, they're food abusers. I work with food abusers. It's always eating disorders, right? I work in the eating disorders field. I have an eating disorder, never a I'm not a food abuser. But think about that. I mean, in many ways, eating disorders are first cousins. There's a lot of similarity with addiction and the neurocircuitry of addiction and the genetic contributions. But for some reason that we attribute this abuse terminology, have adopted and propagated this abuse terminology and describe people who use drugs as drug abusers. So does it matter though, right? This is the question I ask myself, like, well, is it all political correctness? And I'm the last person to be kind of up on a pedestal saying, you know, you should be saying this and saying that. But I've convinced myself through studies that we and others have done that it does matter. It is not just political correctness. It is not just being nice and accommodating somebody, but rather it has real impacts. Now, we did these studies a while ago. They've been replicated in other ways by other groups. But what I was interested in was that particular terminology that's been adopted, was adopted in old DSMs and has been propagated through our National Institutes of Health, which we're trying to change the names of right now to remove the abuse terminology out of the National Institute of Drug Abuse, for example. But if you think about that terminology, calling someone a drug abuser or a substance abuser, it's akin to calling someone a child abuser, right? We use that same terminology. What does it imply? It implies that somebody is engaging in willful misconduct. They're choosing to do it, and therefore that might increase the approach of, you know, approaches to more punitive ways of dealing with it. People should be punished for bad behavior, as opposed to describing the same person as having a substance use disorder implies some kind of medical malfunction, as I've already shown you and what we know to be true, and which has already been adopted by the eating disorders field. So what did we do? We randomized these two different terms, two different ways of describing someone with a drug impairment as a substance abuser or as having a substance use disorder. And what did we find? We found that these were clinicians. These were PhD, MD clinicians, 600 of them. They were randomly assigned to receive see the same vignette, same description, but describing someone in the vignette either as a substance abuser or as having a substance use disorder. And those who were exposed, remember these were mental health doctoral level clinicians, those who were exposed at random to the same person described as a substance abuser were more likely to view that person in need of punishment, less need of treatment, and more to blame. When we replicated this in a similar study in the general population, what did we find? Even bigger differences. Look at these the size of these, magnitude of these differences. When someone is described as a substance abuser, they're viewed as less in need of treatment over here on the left. That's the white columns are people described as a substance abuser. More in need of punishment. Look at that compared to those described as having a substance use disorder. More of a social threat. More to blame for having their condition. Less likely to be exonerated or freed because of their condition. And more likely to be able to self-regulate. So they're engaging in willful misconduct and should be punished. So even among well-trained clinicians, the same individual is judged differently at random, depending on what they're exposed to and how they're described. And this is very interesting to me because it means that even when we don't mean it, even when we don't really mean anything by it, but we use those terms, there's an implicit unconscious bias which is triggered when we use certain words. So below our explicit consciousness, we are more prone to view the same person differently and more punitively, particularly around this word abuse and abuser. There are many other terms that we use in the addiction field that are quite popular still in our culture, which have made their way into clinical settings. I have heard clinicians at arguably one of the top hospitals in the world, Massachusetts General Hospital, using terminology like dirty urines, dirty and clean urines. We don't use that kind of terminology in any other area of medicine. Why do we use it in the addiction medicine world? Now, we are changing, but we need to keep our foot on the gas here in terms of trying to shift this language. And there are many guides now The Associated Press Guide is a great one that has a lot of the recommended terminology to avoid and to use. And here are just some examples. We've heard them already today. To use person-first language. Don't use the term abuse. And it's not substance abuse disorder, by the way. It's substance use disorder. We need to get rid of that term abuse. It's a good first step, I would say, that you're using the moving in that direction, but we need to get rid of that abuse term in particular. That's where the evidence shows that is really pernicious and punitive. Again, using person-first language and getting rid of this notion of dirty and clean in our public health and clinical settings. So with that, I want to thank you for your attention, for having me. And I just want to let you know that we publish a monthly bulletin that updates the world, we hope, on the latest science, translated for the benefit of the public good. You can sign up at recoveryanswers.org to receive the free bulletin. Thank you for having me.
Thank you, Dr. Kelly. If somebody were to tell me that I was going to have to pull out or distill Dr. Kelly's presentation, I probably would have run the other way. That was so much incredible information. And I want to, for all of you that were sitting there jotting down notes as I was, things that I was trying to remember, what I will say is that we are going to be sending out a resource packet to all attendees with language guidelines and a summary of this research. So if you missed some of it, we will send out a packet. I want to say thank you, Dr. Kelly. I think Dr. Kelly and Maya touched on some really connecting points. I think one of the things that really stood out to me is this: it's their fault or it's not their fault. I hear that a lot. I hear that a lot often in Facebook comment sections, which are things that I shouldn't be reading, but I do often fall prey to. And I think, what Maya said about this fear of losing control, the dominant culture wants a sense of control and order, orderly society. And so a way to kind of other people is it's their fault, right? And how dare they want to lose control or even seek out pleasure. So thank you, Dr. Kelly. That was incredible and so much, so much knowledge. So we will send out a resource packet. Don't you fear. So we are going to move forward. Our next presenter is Diego Arene Morley. Diego currently serves as the program manager at RICARES, overseeing the delivery of direct peer support services to Rhode Islanders seeking all pathways to recovery. Diego first began working with RICARES as an intern with the faith-infused recovery efforts, FIRE, to organize the state's first interfaith memorial ceremony to victims of overdose in the summer of 2017, which was a beautiful event. Diego then moved into the role of grievance investigator for certified recovery houses in Rhode Island, and then into the role of community engagement coordinator before taking on the role of program manager. Wow, you have done a lot the last few years, Diego. Diego passionately believes that communities of recovery and their allies are uniquely positioned to both design and implement new models of public health and criminal justice. Diego came to his personal recovery from co-occurring mental health and substance use disorders after graduating college. As a survivor of childhood sexual abuse, Diego intentionally began his recovery journey on an AmeriCorps tour, working with elementary school students in Central Falls, Rhode Island. Diego pursued the peer recovery specialist certification to support other binge drinkers seeking deeper healing from post-traumatic stress, anxiety, and depression. Welcome, Diego.
Thank you, Annabeth. Thank you, everyone. Ashley, Dr. Kelly, thank you so much. Bienvenido a todos. One of Bob Dylan's most famous songs is called Spanish is the Loving Tongue. featuring Joan Baez, one of the greatest Mexican-American singer-songwriters of all time. Nearly the whole world recognizes the uniquely expressive qualities of the Spanish language. And that is one reason why this event feels particularly important to me today as a bilingual Salvadoran American. The vocabulary we use to describe the world and other human beings actually will define us. I am a person in recovery from alcohol use disorder and trauma and mental illness. What that means for me is I have not used any alcohol in almost 3 years. I participate actively in therapy and take medications that support my recovery. In preparation for this event, I spoke with the Rhode Islanders most involved in the communication and delivery of treatment and recovery services for Spanish-speaking populations in this state. I spoke with 1 of 3 bilingual Latino clinicians in Rhode Island. There are about the same number of bilingual Latino psychiatrists, which means their caseload would currently be in the thousands if people were actually getting the help that they wanted. And those numbers don't even include the tens of thousands of Rhode Islanders of Portuguese and Cape Verdean descent who may speak a different language at home. 1 in 5 Rhode Islanders speak a different language at home. I spoke with a social services coordinator who has worked for 10 years in the legal system on behalf of families. They themselves experienced homelessness and separation from their children as a young mom. I spoke with someone who has probably saved tens, if not hundreds, of lives through naloxone distribution for people who use drugs and speak Spanish. Imagine how many people are employed in Rhode Island to teach a family member how to administer naloxone to their loved one who uses drugs in Portuguese. None. I don't know a single person. This event really is about the importance of language in our lives. One of the stories I heard, which is devastating, is a pure misunderstanding between a government interpreter and a mother that resulted in a family separation. The translator took the mother's expression of disbelief that this was happening to her family as a refusal to acknowledge that the boyfriend was abusing the children. When she said, "I can't believe this is happening to me," the translator translated that to mean, "I refuse to believe my boyfriend is abusive," and therefore her children were taken from her. Pure misunderstanding, totally preventable. I heard about a training program for Spanish-speaking clinicians that trained at least 1 of those 3 clinicians I had mentioned before. The training took place in 2000, 20 years ago. There's not been one since then. We have to talk about this. But what role do news media outlets specifically have on a public health issue? So let's start with a few examples. One which we've already kind of touched on. One political candidate began a successful campaign for president by insinuating that Mexican-American immigrants, like Joan Baez's father, are contagious with addiction. Listen closely to exactly what they said. Quote, "When Mexico sends its people, they're not sending their best. They're sending people that have lots of problems. And they're bringing those problems to us. They're bringing drugs." I think you know what he said after that, but for some reason we never talked as much about that first part. I wonder why. That's the power of a citizen at all. 2 days ago, NRI, the Providence Journal, the Pawtucket Valley Breeze, and others all wrote about the arrests. And they only got quotes from law enforcement. One officer said, quote, "Any impact we can have as far as taking these dealers off the streets and taking their products off the streets, we hope will help. No one who works in the substance use and recovery field was interviewed by any of those publications. This was 2 days ago. No one on the governor's overdose prevention task force was interviewed. Not a single doctor was interviewed. So I decided to look up the previous criminal records, if any, for each of the 20 individuals arrested and labeled as dealers by all the major Rhode Island news outlets. What I found was that at least half of those who had been arrested had never been arrested for anything more serious than simple possession, shoplifting, or driving with a suspended license. So of all these dealers, none of them, about half of these 20 dealers, previously, the most significant thing they had ever been arrested for was possession or driving with a suspended license. At least half of them, I can turn off my video. It's even better. At least half of the people that were arrested had been court-ordered to addiction treatment previously. One of them, who was over the age of 50, you could see, had paid their previous court fines for a previous possession case over the course of 3 years in $30 increments every 2 months. These dealers are not kingpins. They're not dealers. They're not cartel members. And yet no media outlets decided to look at all of these records, which are public. Instead, their names just appear in print as dealers without any trial or evidence. That's the power of a stigma. One news outlet reported that one of these individuals was arrested and was being charged with possession with intent to deliver naloxone. That's what it says on the website right now. Naloxone is the drug that reverses an overdose. The Surgeon General of the United States recommends everyone carry naloxone, but how many people are going to read that and think that naloxone is a drug that will get you arrested? If any of these news outlets did any interviews with recovery organizations who work in downtown Providence, like RICARES, or who work in Woonsocket, like Community Care Alliance, like Project Weber Renew, you would have already read that many of those individuals arrested struggle with addiction. And you would have read that actually after large drug busts, overdose increase. They don't decrease because people just end up buying drugs from a riskier source. Every single researcher who I work with at Brown University School of Public Health will tell you the exact same thing, but they were never asked. Why weren't any of us asked? Was it because, as the president said, they are people with problems? I want to speak to the Latino community in Rhode Island and the immigrant community in general for a second. Did you know that lawful permanent residents can be deported for simple possession of a drug? On average, 40,000 people are deported every year just for having an addiction, just for a simple possession. That's about 25% of all the deportations that happens every year. So what this means is if you care about deportations and rights for immigrants, then you also have to care about drug policy. I will add that RICARES will support any person seeking recovery regardless of citizenship status, no questions asked. This event is not about whether a single word used one time is quote unquote offensive or not. It's about starting a newsworthy conversation about what is happening in this country this week. The war on drugs is why Breonna Taylor is dead. The war on drugs is why over half of those 20 people arrested in Woonsocket 2 days ago who have a documented history of needing treatment were called dealers by all the major Rhode Island news outlets. The war on drugs is why we deport tens of thousands of people a year. Does any of that sounds like it will inspire recovery or wellness? That's not just on the police. That's on all of us who continue to think that we can live in a society where some drugs are regulated and other drugs are criminalized. It seems like all these issues of mass incarceration, deportation, police violence, COVID-19 mortality are totally separate issues, but they're actually not. To our allies in the Spanish-speaking media, you have a role in helping to change the stigmas against mental health and addiction in our communities by using person-centered language. Mayor Elorza is setting an example for Latino families by sharing his own family's recovery story. The City of Providence and RICARES have collaborated to translate the AP guidelines on using person-centered language. We will translate all of our stigma trainings and naloxone presentations into Spanish, like the integrity of our families and neighborhoods depend on it. We'll work with any Spanish language media and business to help them become the first designated empleo aliado a la recuperación, or recovery-friendly workplace. Instead of reporting about drugs and quote-unquote dealers, we need to be reporting about the individual people, human beings, who use drugs and the people who formerly use drugs to bring their lived experience to the policy process. That's the real news story. Thank you. Gracias again for having me. Thank you, Annabeth.
Thank you, Diego. I really appreciate all that you said, and I think you did a really beautiful job of bringing in pieces from each of the presenters today. And I hear a lot. I think it was beautiful to have you speak after Dr. Kelly to really drive home words like problem and, you know, stigmatizing words and how they actually affect people. Today I've been thinking a lot about that phrase that we used to say when we were kids: sticks and stones may break my bones, but words will never hurt me, which I know is like an anti-bullying thing, but I think today we see that words matter and that words really do hurt people. So thank you, Diego. Thank you to all of our presenters. I'm really excited that this is recorded because I'd like to go back and re-watch this already. You all have incredible insight and stories and research, and I really appreciate everybody. So we're going to move now into the panel discussion. And I'm going to introduce Dr. Elizabeth Samuels, who is going to be moderating our panel discussion today. Elizabeth Samuels, MD, MPH, MHS, is a board-certified emergency physician, health services researcher, assistant professor of emergency medicine at the Alpert Medical School of Brown University, and the consulting assistant medical director of the Rhode Island Department of Health Drug Overdose Prevention Program. At RIDO, she leads implementation and evaluation of Rhode Island's statewide ED and hospital standards of care treatment of opioid overdoses and opioid use disorder, and works with community partners in overdose hotspots to develop and implement data-driven, evidence-based interventions to reduce overdose deaths. She has recently launched Rhode Island's buprenorphine hotline and an ED-based community health worker peer recovery specialist initiative at Rhode Island Hospital to address the social determinants of substance use and recovery and link patients to harm reduction services and addiction treatment. So please, let's welcome Elizabeth Samuels. Welcome.
Hi, thanks, Eve. Thank you so much. First, I just want to say thank you to all of the amazing speakers and all of the engaged participants. I know many of you, and I feel really honored to be able to moderate the discussion with this panel. I learned a lot, as I think many of us did, and I definitely feel inspired and energized after hearing everyone speak. And as always, I feel very lucky to live in Rhode Island to get to work with all of you on addressing these very key, important issues. The consequences of racism, discrimination, and stigma are literally life and death, as our panelists all highlighted. And we have an opportunity to really make important and impactful changes that can save people's lives. So, and I just want to note, this is just the beginning of a conversation. I want to thank RICARES and the City of Providence for creating this forum. This is a really good example of how government and community partnerships can really center the leadership of people with substance use disorders and people who are living in recovery. They are the most experts in their own experience and about how stigma impacts their lives. And I think this is a great example of the kinds of events and initiatives we should seek to have moving forward. So we have about 20 minutes for questions. You can put questions in the chat and I can read them to our panelists. You can either send them directly to me privately, or you can send them to everyone. I think everyone should have that ability. But just to get us started, there are some people, and this was touched on, I think, by a couple of folks that have advocated to reframe stigma as really talking about discrimination. I'd like to hear people's thoughts about whether this is an important distinction, or are these things that you can actually separate out, and how we can best try to reduce discrimination experienced by people with substance use disorders. I don't know if anyone wants to go first, and people had some concrete examples, but I'd like to hear. Dr. Kelly did mention kind of separating out discrimination and stigma, but if anyone has specific thoughts about whether those are things we should be moving away from talking about stigma and more towards discrimination, or doing both at the same time.
I guess I can say something here.
That'd be great.
I think that it's kind of a complicated question, and I think there are situations in which you need to use both terms, because the stigma is internalized, and I mean, maybe you could have internalized discrimination, but I do feel that they are somewhat separate, and I get why discrimination is a more powerful destigmatizing term, but I think there may be still a place for stigma to be used.
Hello, my name is Kevin, and I'm from RICARES, and the way I wanted to ask the question is kind of just real wordy, but one of the things I wanted to ask or make a comment on, I'm gonna make this really, really short. I noticed through my lived experience that the powers that be, doctors, lawyers, judges, everything, they know when to use stigma. And what I mean by that is, if I was arrested for cocaine, they'll never use the word arrested for drugs, cocaine, blah, blah. They'll say arrested for a substance, controlled substance. They know when to communicate the non-stigmatizing words to their colleagues. And then they know when to use the stigmatizing words during an interrogation. So I think a lot, not all, but it's just a comment. I think that these people are very conscious of the behavior that they are partaking in. And also that to get that switch in the mind is going to be a difficult thing, because the stigma in the boardrooms or jury rooms play a powerful role in getting the conviction. If you go into a jury room and say, well, he's a substance use disorder, that lightens it. And I think they're very educated in that. This is not something that's happening in the darkness. It's happening in the darkness to those that are at the center of the circle. What I mean, those that are out there with the substance use disorder. You know, people, I'm very visual. If I go by a place, and I'm gonna cut this off real quick. If I go by a place and I see people where it's a heavy substance use disorder going on, if I see someone who is hygienically not up to par, so to speak, I say, oh, he's dirty. His clothes are dirty. And so with that comes also when he uses and he has a urine analysis, his urine is dirty. So those things kind of go hand in hand. But believe this, those in the powers that be, they are very aware of the stigmas, you know, and I think it's the substance use person that's not as educated about the stigmas and what's happening in their life. I just wanted to share that because that was kind of hard to put in the chat. Thank you.
Yeah, no, thank you for sharing that. I think that actually connects really well with some of the things that Ashley and Machiste mentioned, just looking specifically around like the microaggressions. Ashley explained a little bit she experienced from the governor, what someone might call a microaggression. It's like super deep internalized bias, right? So they might not say, well, I'm not using the wrong language, but people know what they're doing. They know what some of the implications are. So I guess the question is, how do we go deeper? We've made some recommendations for language that the media can use, but what does it mean to go deeper to have anti-racist policies? What does it mean to go deeper to people to really reflect on their biases, and how do we do that? Yes, please go ahead.
Well, I think it's much like recovery. You would first have to admit that you have a problem. You can't see how to address your racist language or the intersectionality between racism and substance use disorders if you don't believe that there's a problem with what you're saying or what you're putting out. Members of the media are supposed to be individuals who broker in information, right? They gather it and then they process it and then they disseminate it. And if you are processing these things, as I said in my presentation, in a newsroom that is predominantly monochromatic, you're not going to get feedback from anyone that has some sort of a differing viewpoint. Now, you might speak to one individual in the boardroom or in the newsroom or wherever. You might play Ask a Black Guy and ask that one person that you know and believe that they speak for every person of color, which we do not. We actually have varying viewpoints about a lot of different things. Some of us like country music. And so I think that to really grasp or to really come up with some sort of an action plan in regards to addressing this, you have to address the fact that there's a problem.
Yeah, that's a really good point. Diego, Ashley, do either of you have anything you want to add to that?
Yeah, so for me, I mean, education starts at home, you know, like I spoke about earlier, you know, I was taught things about substance use disorder. You know, I was taught that people are bad, people who use drugs. And for me, you know, teaching my own kids that addiction is a disease, is destigmatizing, because when my kids see somebody panhandling on the corner, you know, my kids don't have the assumption that that person is a bad drug addict. My kids have the assumption that that person is experiencing something called homelessness. My kids have the assumption that that person may be ill. You know, my kids think I'm a hero, a superhero, because I carry around Narcan. You know, maybe go home and talk to your kids today and see what your kids know about people who use drugs.
Yeah, that's really helpful. And then I guess the question becomes, I would have, is like, how do we all recognize what is, in what forums, and how do we all recognize that we have a problem, right? So media, educational institutions. Ray in the chat mentioned that he's working with people in faith communities. Where do we get where many places we get messages and reinforcement of those messages about substance use disorders. But I think, as was mentioned in one of the earlier talks, is that, you know, the underlying issue of criminalization of substance use, how that's tied in with racism, and that really underlies a lot of the stigma, discrimination, and bias that people experience.
Yeah, I mean, I was just going to say, I think we have to decriminalize if we are going to get anywhere with stigma on this, frankly. I believe that when you're simultaneously stigmatizing and destigmatizing, it just can't work very well. And I know that can seem radical to a lot of people, but I don't nobody has ever been able to give me a good argument for why putting someone in a cage for possession of a substance is going to do anything helpful.
A couple more questions that we had in the chat is, one is, what role should doctors have when advising best practices when it comes to drug policy? I don't know if any of our panelists want to, I have my own opinion about that as a doctor, but I don't know if any of our panelists have a specific opinion about that, either from their own experience trying to advocate for drug policy or advocate with physicians or scientists for drug policy, but I'd be interested in hearing some people's point of view as well.
I mean, I have definitely had some experience trying to get physicians to be better on this issue. And I think there's another policy issue that interrelates with that, which is that physicians are the guardians of the opioids and the guardians of the controlled substances. So this creates an inherent bad relationship between people with addiction and physicians, because we're the people that can make you lose your license. And until we can get rid of the horrible Supreme Court decisions that meant that maintaining an addict is actually a crime, except for some very limited circumstances, we are going to have very difficult relationships between people with addiction and physicians. And I think doctors also, they like their area of expertise. They want to expand it. They would appreciate this being seen as medical. They don't want to be sending people off to get arrested. So I think there's a real opportunity for people to work towards decriminalization and more compassionate policy in general with physicians. But first, you have to get through the incredible stigma that physicians often put on people with addiction because of that drug guarding relationship.
Other thoughts, experience? Yes.
I'm a novice to this and working in peer recovery, and it's coming along really well, I think. And I was listening to Machisti and the things he was saying that was really pulling things together. When you say decriminalization, to a lot of people, that sounds like defunding the police. In other words, just take drugs, don't make them illegal no more. When I was active, so to speak, and I was incarcerated. I was never incarcerated for substance control, having substances on me. I was convicted because of the behavior behind my substance use. Before the behavior, the stealing and the different things like that there. And I can understand if a person is arrested for having controlled substances, and then in their system there is no substance, they are just what we call, quote unquote, dealer, and selling it off the market, selling it, is that something that will be decriminalized? Because there's so many branches on this tree that can be pushed back on when you say decriminalization, when you say that. And so that's the one thing I kind of think about, because there has been behavior with substance use disorder. The behaviors have been tragic, and there has been victims in other people's lives due to substance use disorder. So when you do say decriminalization, what are you actually saying?
I mean, I'm talking about decriminalization of personal possession as a first step. I'm not talking about decriminalizing stealing. And decriminalizing sales would be the term legalization. And I think we have to get there eventually. But I think first we need to start by not arresting people for possession of substances. All that does is perpetrate racism and stigma. Lots of white people don't get arrested all the time. We get in recovery just as well as Black people. It is not helpful to be arrested. So, in fact, it's harmful. So I think that giving police one fewer excuse to arrest Black people would be a good thing.
Okay.
So we've got just about 5 minutes or so. I do want to just see, particularly since this was trying to give us some language and information for the media, if any members of the media have any particular kind of questions for our panelists about how they can both prevent perpetuating stigma and then help reduce that in their work going forward, covering these very important topics. Any media questions? Is everyone able to see the recommendations from the Associated Press? Yes, people got them in the chat. Okay, so no questions. If you do, there's obviously there's opportunity afterwards for if people do have questions or they want to kind of engage and run topics by people. RICARES has generously offered to provide ongoing trainings and engagement. And it looks like the guidelines just got pasted in the chat again. Thank you for that. It looks like someone has a question about dealing with family members and stigma with family members. Now, is anyone on the panel, can they talk a little bit maybe about your experience kind of engaging with family members, either of your own family members or family members who have a loved one with a substance use disorder? Because family members, as we all know, can really play a key role. And Ashley mentioned in her talk about the fears of discrimination and bad experiences really being a big barrier to accessing services, and families can play a really key role, I think, in facilitating and providing support people getting through some of those barriers. So I'd love to kind of hear people's experiences and perspectives about that as well. Or even the types of treatment that people try to engage in, whether it's medications for addiction or whether it's harm reduction. Families can be huge on that. Ashley, I saw you unmuted.
Yeah, so just very recently I've been working with a young man who's about 20 years old. He's very young, who also deals with a lot of behavioral health issues and mental health issues. And he's been overdosing a lot lately. Through the COVID pandemic, I have just recently counted that I've supplied this young man with over 50 doses of Narcan in the past 5 months. So he is somebody who is a heavy user, and his family is trying very hard, in their words, not to give up on him. His mom doesn't understand addiction. She comes from a Hispanic community. She comes from somewhere where, you know, addiction is seen as if you have anything to do with drugs, then you're in a gang. You know, that's how she associates drug use. So it's very hard to go into those types of other communities. You know, I'm a white woman who has no idea what this woman's culture is like, and I am trying to explain to her that her son essentially has a disease, and, you know, no doctor has ever explained this to her. Nobody's ever explained this to her. And when I look at all the times her son has been through emergency room visits for overdoses, through treatment facilities, through residential treatment, and that nobody has taken the time to sit with this mother, not only explain to her what is going on with her son, but also how to use Narcan that could potentially save her son's life, really baffled me that, you know, nobody's ever took the time to do that. I mean, he's somebody who, since he was 14 years old, has been in and out of, he's been in almost every facility in Rhode Island. So for me, just thinking about that, I thought a lot about what Diego was saying and how the Hispanic community, there's a big gap in the Hispanic community when it comes to treatment for addiction. But it just still gets to me is that, you know, how can we have these people who are going through this and they've never, ever been explained what they're actually going through? Because, you know, it does affect his mother, who is at home trying to figure out, she thinks she has to wait for 911 to help her son, you know what I mean? And the reality is we have Narcan that she could have in her house, you know what I mean, and give her some type of peace of mind. You know, all she knows is that she doesn't want her son to die, but she doesn't know how to help them. So, I mean, I think it would be, you know, my job is not to outreach to families, but sometimes that's what my job is, because that's what we have to do.
And I'd love to share just a little bit of the family piece of it myself, if that's okay.
Yeah, go ahead, Lori.
So it actually wasn't until I started changing my view of substance use disorder as a mom, and through experiences that I had with like first responders and the emergency room. And it wasn't until I started to change I opened my mind up to substance use disorder as a disorder and not a choice. And once I started to look at it as a healthcare crisis, that's when everything changed. How I approached my my son and his substance use disorder. It became a lot more compassionate, a lot more caring, healthy boundaries, certainly healthy boundaries, but changing my view and really digging in and learning, right? Reading everything that everybody's on this panel. I've read and heard everyone speak in the past. And it was through that research and that digging that helped change my perspective of everything. And now it's also, for me as a family member, it's about working with other family members, not necessarily to change their views, but to help them do their own research and maybe open their minds up to an alternative way of looking at this. And it was, I mean, I witnessed and I experienced a lot of the stigma and discrimination against me as a family member, and how I was, enabling him. And I also I got to witness the stigma towards my son in the emergency room, and just literally sat there and was like, no, if you were treating me like that, I wouldn't ask for help. No way. I can't wait to get out of this place. So my question, so that's just bringing my family perspective to the picture. But that's my biggest question too, is how do we get this idea of stigma, discriminatory acts to first responders, to emergency room staff, to medics, to law enforcement? Because for me, it seems like that could have a huge impact. So it's almost like I want to attack that first.
I mean, one thing I would just say is that this is why the media is so important, because the more the media can get rid of this bad language, the more the media can tell compassionate stories of recovery, the more the media actually tells the truth about drugs and doesn't engage in distortion like arresting people for naloxone. The better we get, the better the rest of the public should get, because so many people get information from us. Also, like TV dramas, plays, art, music, all of these things are places where these stereotypes get reinforced, books. So getting stuff into the media can help change the culture in a larger way. I agree that there should also be education aimed directly at first responders, because often they have terrible beliefs about people with addiction, and they're quoted in the media saying, I don't want to revive people anymore, they should just get 3 chances. And they never say that about people with heart attacks. So I agree, we need to reach that group. One way is through the media. If there are ways to work more directly, it should be done. I agree, somebody should do it.
So I know that everyone has a lot that they want to say about this. This is a really key part near and dear to my heart, because I work in the emergency department. But we are running very close on time. So again, this is just the beginning of the conversation. Anna Bess, I'm supposed to hand it over to you, I believe.
Yes.
Yeah.
Thank you.
Yeah.
I am sorry that we can't get to all the questions. I encourage you all, especially those of you in working in media, working in the written word, to reach out to RICARES. If you have further questions, if you need further resources, they are here to help you. Like we have said a few times today, you will receive resources following this event. You will receive the APA style guidelines. You will receive, follow-up information that was in people's presentations. And please feel free to reach out to RICARES. They are incredibly open and always there for questions and comments. And I want to say again, a big thank you to RICARES and the City of Providence for bringing us all together and putting this together. A big thank you to our sponsors, the Brown School of Public Health, Project Weber Renew, the COBRA on Opioids and Overdoses, BHCDH, and the Rhode Island Department of Health. A big thank you to all of our, everybody who spoke today. Mayor Elorza, thank you for your work. Thank you to Maya, thank you to Ashley, thank you Machisti, thank you John, thank you Diego, and thank you Elizabeth. I want to say that today was just the beginning of a conversation, and what we're asking you all to do is to take a pledge with us, to try. We're not asking you to get it perfect. We're not asking you to change all of your languaging overnight, but to take a pledge with us to become an ally and to support, first person centered language and destigmatizing language. So if you feel so called, you can stick in the chat box, I pledge to become an ally. I think it'd be really wonderful to see people pledging, just to see that written out in Word. Thank you everybody for being here. I'm now going to introduce the woman who will give our final remarks. I also want to say again, you are the heroes in the story. You are truly the heroes. You are the ones that will turn the tide. And don't think that your efforts are going to go unseen or are not going to help change the world. So I love seeing all these. I pledge to be an ally. Thank you everybody for being here. So our last speaker is Director Catherine Power. Catherine Power has a long record of service and achievement in the fields of behavioral health and developmental disabilities. Chosen by Governor Gina Raimondo to serve as the director of the Department of Behavioral Healthcare, Developmental Disabilities, and Hospitals, which is BHDDH. Power returned in this January of 2020 to a role she had held for more than 10 years. As the director of BHDDH from 1993 to 2003, Power led Rhode Island to high achievements on many fronts, including substance use recovery programming, deinstitutionalization, say that 5 times fast, and reducing seclusion and restraint. After leaving BHDDH in 2003, Power went on to serve as the Federal Substance Abuse and Mental Health Services Administration, SAMHSA, and was later named the agency's Region 1 Administrator. A retired captain in the U.S. Navy Reserve, Power received her bachelor's degree in education from St. John's College in Emmitsburg, Maryland, and her master's degree in education and counseling from Western Maryland College. She is also a graduate of the Toll Fellowship Program of the Council of State Governments, and she has completed a program in senior executive leadership at Harvard University's Kennedy School of Government. Welcome, Catherine Power.
Thank you, Annabeth. Hello, everyone. Good afternoon, and thank you for inviting me to join you today. I am delighted to be a part of this, and I just want to say that it was a stunning lineup of profound presentations, and it was wonderfully intriguing. My thanks to the City of Providence and to RICARES. I just have the final word, which is a really important place to be. And the final word is that words play a very important role. They have meaning, and they convey implied thoughts, and they convey implied attitudes beyond their strict definitions. They have the power to build up and the power to tear down. And when they're not used with careful thought, they can distort what we really want to say and what we intended to say. In the mental health, addiction, and larger behavioral health context, the term stigma is often used to indicate negative attitudes associated with people with mental illnesses and substance use conditions, and the concepts that are embedded in the term stigma are frequently used to explain low rates of seeking care, limited access and availability of treatment and services, and an underfunded mental health and substance use disorder system. The terms that reinforce these negative attitudes and stereotyping all connote blame, and they connote victimhood, placing shame on the person who experiences a mental health or substance use condition as if they had an inherent mark or stain upon them. And I think Ashley referred to this very directly. An individual with a substance use condition may and is often described as an addict or alcoholic. An individual with schizophrenia, often referred to as schizophrenic. A person with a developmental disability may be described as crippled. This labeling reduces a person to a specific condition rather than acknowledging the whole person who has many traits, and it also implies a negative and narrowing bias. When we refer to an individual as a person with the condition, we are using people-first language, and Dr. Kelly referred to person-centered and people-first language. We say a person with schizophrenia or an individual with a developmental disability. And I might add today, I was struck by the fact that no one mentioned the Institute of Medicine. When I was at SAMHSA, I adopted the language of the Institute of Medicine, which refers to terminology that says an individual may have a mental or substance use condition. That's what the Institute of Medicine has prescribed, which I think is a very generic and broad way to think about it. This conversation today has shown us that we do not need to reinvent the wheel. There are guidelines that are readily available, and we ask that everyone commit to following them. We know it is the right thing to do. We know that it will help individuals living with mental illnesses, substance use conditions, or those with any other kind of disabling condition to feel that they can then speak up and to seek help. I do not think it is an understatement to say that this could make a significant difference in someone's life. At this Department of Behavioral Health Care, Developmental Disabilities and Hospitals, one of the many things we do is to work with regional prevention task force coalitions, which function as the feet on the ground in our communities, ensuring that the strategies and programs developed at the federal and state level reach every city, every town, every neighborhood. We have asked that the regional coalitions attend today's workshop, and moving forward, this department will work with RICARES to provide training for regional coalitions on respectful language. And the coalitions are going to follow up with local media to promote the adoption of the AP guidelines. That is powerful action. We're also encouraging partnerships between the coalitions and the recovery community centers to follow up jointly with local media as a way of promoting wellness, positive behavioral health, community connectedness, hope, and recovery. By opening this dialogue, we will be reinforcing all of the things that have been discussed here today. Our behavioral health and developmental disability services staff are very cognizant about language, wanting to ensure that every Rhode Islander knows that we value and place importance on the health and accomplishments of every single individual. We're committed to making sure that everyone who may have challenges in their life feels no discrimination or shame regarding those challenges and feels no discrimination or shame for seeking assistance and help. I want to thank you again for the opportunity to take part in today's discussion. And most importantly, remember, words matter. Thank you, Anna.
Thank you, Catherine. Thank you, everybody, for being here. Have a wonderful day.